Usually, when we talk about patients and patient engagement and patient experience, doesn't matter where you are in which setting is kind of the cherry on the cake. We say, oh, there's all these people, they speak, and at the end it's like, oh, we have a patient advocate. We want to know what they think, or the same in a grant panel, or whatever the situation is. So I'm going to flip it now, and I'm going to give first the podium to Nick. He went through a cancer journey, and it takes special courage to people not only go through a cancer journey, but then afterwards become advocates for that and share their story and their perspective and their insights. So every time I'm faced with patients that are open to share these are the superhuman patients that we face every now and then in the clinic, or most of the time in the clinic. So Nick was part of a program that's going to be discussed. He's a Toronto-based film producer whose shorts, including Tidal and Elegy for Glacier, have screened internationally. He also holds a multi-factor authentication in creative MFA is Master of Fine Arts. Sorry, we're in the digital stuff. In creative producing from Columbia University, and he has experience in development at Blumhouse Productions. So please, Nick, thanks for being here, and please, I would love if you can share some of your views and thoughts when we're talking about patient monitoring and how can these can affect, enhance, detriment, or harm the patient experience from your perspective. So thank you.
Sure. Hi, everyone, and thank you for inviting me to be part of this. So yeah, I guess I'll quickly touch on my own cancer journey. I was diagnosed with testicular cancer back in 2018. Very quickly moved through that process and got assigned to Dr. Hamilton here. And I was offered to be part of his Watchman program, which he'll get into and I won't touch too much on. But it essentially was a remote monitoring ecosystem. I don't know if there's a better way to explain it. But it meant that I didn't have to go into Princess Margaret to receive any type of communications with Dr. Hamilton and his team. And that kind of opened my world up in a big way. During my 5 years of surveillance, I ended up, while I was living in Toronto originally, I ended up moving to New York and doing some of my monitoring there. And my whole care was seamless between cities. I ended up in Ottawa. The pandemic happened. I ended up back in Toronto, and my care has kind of been consistent across the entire board. So without the remoteness of that opportunity, I really wouldn't have been able to do a lot of the things I did, which part of what was mentioned. I ended up doing my MFA, Master of Fine Arts, in film producing down in New York. I did a huge career shift, and it's kind of allowed me to come back to Toronto with that whole experience. So, you know, we'll get into it, I'm sure, with a lot of the questions, but for me, the remote monitoring has just been a consistent and seamless experience that has allowed me to kind of live my life and let the cancer be something that's monitored elsewhere. And I found that it was just an awesome experience. And I'm so glad I didn't have to go in that often at all. Like actually, me seeing Dr. Hamilton here is, I think, like the first time in person since 2018. So it's nice to see you.
That's amazing. Thanks for the candid sharing. It's great to have you back and have you well. So, in spite of Rob, obviously. So with that, we'll move to Dr. Jones. Jennifer is the Butterfield Drew Chair in Cancer Survivorship Research, and she's the director of the Rehab and Survivorship Program at PM, and she's a senior scientist in the Research Institute and associate professor in both psychiatry and the public health school at the University of Toronto, and she has a very well-funded and robust and successful program focused on translational research around survivorship care. So, Dr. Jones, if you can share with us, I think you have some presentation. And then.
I do, yeah. Great. So I think this is meant to be more informal, informal panel discussion, but we thought, Rob and I thought it would be nice just to give some examples of some of the remote monitoring and tools that we're using and programs that we've developed just to set the scene for our panel discussion. So I know Rob's going to also give a presentation. So, as Ale said, I am the Director of Cancer Rehabilitation Survivorship. We're a large impairment-driven program here at Princess Margaret, so we see patients from across all the disease sites at Princess Margaret. They can be on treatment or post-treatment. And really, we have a multidisciplinary team, many of whom are here today, which is great, rehab team, and our goal is really to get people to address their functional impairments and to address disability and to get them back to their lives and to be functioning as well as possible. So one thing we are is an integrated clinical research program, which means that our research and our clinicians and our researchers all work together. And we're a very innovative program, and really when we hire people, that's something that's really important. We talk about innovation. We want our clinicians to be driving our innovation and coming up with the newest ideas, new things, identifying gaps in care, and then that drives our research program, which is really a nice way to work. So one of the tools that we recently developed that I just wanted to highlight, and we could talk about after, is the development of an app called REACH. And this is an electronic prospective surveillance model which helps to support self-management of physical cancer-related impairments. So the reason we did this is because, as many of you know, a lot of people experience treatment-related side effects and impairments. These are common during treatment and can persist after treatment. And for many people, these often go unreported or underdetected, and as a result, they go undertreated. And these can really impair people's quality of life, impair their ability to get back to work, and those types of things. And we know, though, that they can often be treated. We have treatments. We can provide education to people, self-management education. We have programs. We have clinics, those types of things, comprehensive rehabilitation through our program at Princess Margaret that can address these things that are underutilized, and patients are not necessarily always getting connected to these resources that are available to them. So the idea of a prospective surveillance model is that it monitors patients, how they're doing. You could use it in many different areas. For us, our focus was in rehab, so really routinely just assessing patients' physical symptoms and how they're doing, and then the system can be built to respond to issues that are coming up through that system. So as I mentioned, we developed this program called REACH. It's basically an app that patients can download. It's a self-management tool. It's a patient-directed tool. It has very little clinical role of the clinicians. They really don't have very much to do with it at all. We kind of sort of cut out the clinicians. It's more, as I said, a patient tool. So patients can just register into this. They answer a few questions about their physical symptoms at home. So remotely, they just get prompted to fill it out. They're really short questions, and then they immediately receive responses to their scores. Sorry, I have a few little screenshots, but I'm just going to show you a quick video. Before I do this, I just want to give a shout out. This app was funded through Canadian Cancer Society and CIHR. But also involved our Techna Institute, who developed the app, the Healthcare Human Factors, who helped with the design of it, as well as a national research team. And the REACH app implementation has been led by Christian Lopez, who's my PhD student, who's sitting over there. So I'm just going to, hopefully this works. All right, so this just introduces the app to you.
REACH is an online tool that empowers you to manage your side effects from treatment. People with cancer face many health challenges during and after treatment. These side effects can negatively impact their quality of life and make it hard to get back to their regular activities. There are many resources that can help manage side effects from treatments. But these impairments often go undetected, and only a small number of people get the support they need. REACH helps solve this problem by giving you a place to go to track your symptoms and receive personalized information and support along the cancer pathway. You can access REACH on any electronic device, such as your smartphone, tablet, laptop, or desktop computer. And you can simply create an account for REACH using a personal email and password. Once you register into the system, you will be asked a few questions about yourself. your cancer diagnosis, and where you are on your cancer path. Based on this, the REACH system will tailor what questions you will receive and how often. REACH is easy to use and only takes a few minutes to complete. When it's time to answer your short screening questions, you will get an email and be asked to log in. REACH is a remote system, meaning that you won't be answering these questions when you come to the Cancer Center, and can answer these questions anywhere and on your own time. Based on your answers, REACH will provide you with resources to help manage your symptoms. You may be offered resources such as videos or pamphlets or suggestions for referrals that can be helpful to address any issues you may be having. REACH is meant to help you get the right support at the right time to manage your symptoms and improve your well-being during and after treatment. Let's take control of your well-being and register to REACH today.
Okay, so you get the idea of what REACH is, and I don't want to spend too much more time because I know we have lots of time for discussion, but just understanding that the app itself, was a huge amount of work to build it. There's a whole bunch of logic built behind it, algorithms. We took all of our DART data, which was our patient-reported outcome data we've been collecting at Princess Margaret for years, and did some machine learning analysis to predict what scores should look like and when we need to intervene. We did environmental scans of resources, and this has been we're implementing this across 4 centers in Canada. And these are the 4 different disease sites that we're implementing in, and the different physical impairments that we're screening for. And this was, again, through a whole bunch of different surveys, consensus meetings, and things like that to identify these. So this is just an example. In all 4 sites, we're screening for fatigue. We ask these 2 really quick questions. We have different stepped care responses based on where they are in their cancer trajectory, so whether they're on treatment, off treatment, and their pattern of scores over time. And then we also are screening for lymphedema. So again, this is sort of what an algorithm looks like. It's very complicated, but this is sort of what's built behind the system. And I just want to finish talking about REACH. These are some really great quotes that have come out, and this panel is really about the patient empowerment and how it affects the patient. So I think these are great quotes. The first one is around connection to services. I wouldn't have noticed that I had high fatigue because I just expected that. So these are users of the REACH system. But I got a recommendation to chat about fatigue with my doctor, so that really helped because I reached out to my doctor, and that's when I got referred to the rehabilitation clinic, which I'm looking forward to. People also really like the idea of centralized resources, being able to find everything in one place, so they didn't have to go to a whole bunch of different places to find resources. This idea of sense of control, so not only does REACH provide you with curated resources, but it also gives you the ability to take back some control because you lose a ton of control with your cancer diagnosis. And finally, we do a lot of screening with patient-reported outcomes at UHN and at Princess Margaret, but often when people fill out these questionnaires, it sort of goes into an abyss, and they never get a response. And we've heard that a lot from these patients. What they liked was that they didn't mind answering these questions because they actually felt like there was somebody listening. There was a response to their questions that they were asked. I'm just going to finish. I'm sorry, I'm maybe taking too much time, but I will just finish talking about also our cancer rehab program. So we have, as part of our program, we offer a number of different services, but one of the other things we do is we have one of the main programs that we offer is called the CARE program. It's a structured 8-week rehab program, and it started out as an in-person program. It continues. We do have in-person programming, group-based rehab programming for patients with cancer-related impairments and high levels of disability. But what we found was that, about 40% of the patients when we started rolling out this program were unable to access this program that we were recommending to them for many different reasons, barriers to coming into the hospital. They're too actually fatigued to get into the hospital and those types of things. So what we did was we translated our CARE program to an at-home program called Care at Home. And basically what it is it takes the 8-week program and it just has translated it to be delivered at home. So instead of doing the exercise as a group in person, they're doing their exercises at home, supported with an app called PhysiTrack. We use Fitbits, so everybody is given a Fitbit, and we can track what they're doing at home. We can see their sleep, their heart rate, their physical activity, their sedentary time, all of that, and we can see that live, so we can be monitoring that. They have weekly e-modules that we worked with the Educational Design and Knowledge Translation Cancer Education team to develop. So this gives them the self-management education that they should be getting. So that's assigned each week. And then each week they have a really quick video consultation with their, one of the members of our rehab team, just to check in and see how they're doing, answer any questions, adapt their exercise prescription. They can also see what they're doing on their Fitbit. So I just skip through this, but basically we use this app called PhysiTrack. It basically, we can put their exercise prescription into this app. It has all the videos of the exercises they're supposed to be doing. They can check off whether they've done them or not when they go through open up the app. So they'll follow the videos, they do the videos. I'm going to go through this. And then we also have a clinician dashboard, as I said, that pulls in the live Fitbit data. So we have an API built that pulls in the live data so that when the clinicians have that video check-in each week with their patients, they can see live what's happened on the Fitbit. They can see how active they've been, have they been sleeping well, all those types of things, and they can address that. And for the patient, they have that great Fitbit dashboard that they love. So this is my final slide. Just, again, some really great quotes from patients who have gone through it, just talking about things about how the Fitbit really motivates them. People love their Fitbits. The PhysiTrack and how it helps them to know what to do and how to do their exercises. And just the idea of also having that virtual connection. So we can't just send people home and say, do this. We really still need that virtual, that human connection, that human support, the ability to sort of adapt as we need to. So having that, people say that they know that they're getting that call each week and they know that they're going to be monitored, so that kept them active and kept them doing the things they were supposed to be doing. So I'll finish there. Thanks so much. We have a whole bunch of different different versions of care, and one thing I actually do want to highlight is that we're working with the Allo BMT team right now to take our care program and all the elements of that remote rehab programming and doing a program with it's 9 months with the Allo team. So starting pre-transplant, through transplant, and then 6 months post-transplant, where we're doing entire remote rehab with those patients alongside the transplant, which has really been an exciting collaboration. So thank you.
Awesome. So the use of a tool in the non-physical world to manage physical impairments, pretty genius. So Rob Hamilton, he's a urologic oncologist at PM, an associate professor in surgery urology. We work together very closely. He's interested in prostate and testicular cancer, pharmacogenomics for chemoprevention in prostate cancer, molecular imaging for management of oligometastatic disease and testicular cancer, using novel biomarkers and ways to minimize treatment morbidity. He's a super clinician and a prodigious surgeon, and he trained at U of T, North Carolina, Chapel Hill, Duke University, and Memorial Sloan. He's going to share his story around Watchman.
Thanks very much, Ali. I appreciate the introduction very much. And thanks to the entire CDI team, in particular, Tran Trong, Kelly Lane, Keith Stewart, Mike Lovis. There's a number of other people in this room for your unwavering support of this concept that we've had. Back in 2016, we started, like long before the pandemic, long before anyone thought of remote care. People thought we were crazy to think about monitoring cancer surveillance for relapse from a remote setting. So I'll tell you a little bit about what we did. I'll keep it brief. I was asked to talk just for 5 minutes, so I'll go over this. One slide on testis cancer, just so you know what we're talking about. Again, some of the rationale for why we thought of this back in 2016. Not only did we create the app here at UHN, but we also rolled it out as a randomized controlled trial to try and generate some level 1 evidence of virtual care and its safety and efficacy and patient outcomes. And I'll close with some future aims. So one slide, testis cancer is a young man's disease, as you heard a little bit about from Nick this morning. So 15 to 35 is the most common age group. Thankfully, the majority present as stage 1 disease, and as you can see, the cancer-specific survival is very good. And because of that, nearly all the guidelines recommend surveillance because of those very favorable cancer-specific outcomes. So there's 2 types. There's seminoma and non-seminoma. We don't need to get into the weeds, but what I want you to see is the surveillance protocol that these young men need to follow. So for example, seminoma, every 6 months for the first 3 years, they come for imaging, yearly in year 4, 5, skip a year to 7, skip a year to 9. So you're with us for 9 years in the protocol. If you have non-seminoma, you're only with us for 5 years, but it's more intensive. Every 2 months for the first 2 years, you have to come to Princess Margaret and come and see us. A little bit less intensive as the duration goes on, but you can imagine being a young person, whether you're still in school or new family, new job, new relationships, to put all that on pause once every 2 months and drive for 2 hours and pay $40 to park and come and see us. It can become onerous, and that at times leads to non-compliance, and the patients miss appointments all the time, and I'll show you some data about that. So that was part of the rationale why back in 2016, again, when nobody thought of this concept of watching cancers from afar, we said, maybe we can overcome some of these barriers for the patients. And we're lucky in testis cancer. It's a good way to test it because a physical exam is not really indicated as part of surveillance. We have this very good evidence-based algorithm that we can follow. It's a young, tech-savvy population, so if we could prove that something worked in this group, maybe we could expand it to another group. And then the last point I'll make is that testis cancer is unique, not completely unique to cancers, but when you start to have rare cancers that require truly specialized care, not everyone across Canada knows how to manage these things. And so the more patients that a center of excellence like Princess Margaret can reach out to, the better it is that you serve that population of cancer patients. And so that's one of the arguments of a virtual care system. If Princess Margaret can care for more patients geographically. And then finally, of course, the potential cost savings of running a virtual care as opposed to bringing everyone in hospital. And it's savings for the patient, it's savings for the hospital, and potentially savings for the system. So we'll talk quickly about what we did. And again, it's thanks to many people in this room, and I've listed some here: Healthcare Human Factors, CDI, TECNA. We were fortunate to receive a very competitive grant from TD Bank, TD Ready Challenge, as well as philanthropic support from a number of families to make this happen. What did we do? Well, we built this web-based virtual testis cancer clinic, all built and designed here at UHN. This is no outside input or support. And the idea here is asynchronous communication. So it's not a phone call, it's not a video visit. It is the patient and the physician are interacting at different points in time, as I'll show you. So you'll see in the top left, a virtual appointment is scheduled. The patient receives reminders to go and get their CAT scan or blood test, whatever they may be due for. When the patient's completed that, they have the opportunity to report any symptoms or questions. The healthcare team, again, at a different point in time, reviews that information and feeds back to them through the app. Everything's great, on to the next appointment, or we're seeing something, maybe you should come in and we can discuss this further. And so that's the fundamental basis of our Watchman virtual clinic. And as I mentioned, in addition to building this, we wanted to contribute to the evidence to say, not just, well, we did this and everything looks great. We wanted to have some actual data to show that this may be feasible and safe. And so we designed this randomized trial where patients were randomized either to the standard in-person care, and of course you'll see the asterisk there because, as we all know, in 2020, in-person care was no longer possible, and so the in-person arm switched to a telephone arm, which is a form of remote care, let's be honest. And so we have to keep that in mind when we're looking at the data, but there's still a lot of very interesting things that have come out of this trial. We opened in 2017, over 5 years of follow-up now, and over 650 virtual visits. So that's 650 times that patients like Nick did not have to take a day off work and drive in and see us. Our primary endpoint was patient safety, which I'll show you some data on, and then also satisfaction of the patients, satisfaction of the physicians. So just 2 slides of data. I promise no more into the weeds than that. And these are some of our data about compliance. And if you tick the box, if you miss your blood test by a day or your CAT scan by a day or you miss one of your visits, you get a, quote, non-compliance event. And so you may say, God, that's really high. But again, remember, these are young guys living their lives, and so it's not uncommon that their blood tests get delayed by a week, what have you. So you'll see the Watchman arm, even though it's high in both arms, there are fewer non-compliant events in the Watchman arm. If you look at the median visit delay, 14 days versus 21 days for the Watchman arm. So you get a signal of maybe some improved adherence to our surveillance schedule. And if you look at our oncologic outcomes, we would be worried if the Watchman arm was missing a whole lot of relapses, or the relapses were happening at a later stage of time, if they were worse stage of disease at the time of relapse, and we're not seeing that. If their risk of disease at the time of relapse was worse, we're not seeing that. If we required more modalities to cure their relapses at the time of relapse, We're not seeing that. So overall, our conclusion is that Watchman's safe, and one could argue maybe even safer because of that increased adherence to the algorithms that I showed you. So what do the patients think about it? Well, we asked them, how satisfied are you with your program of active surveillance? And you can see the dark blue lines are the Watchman arm, and nearly everyone was satisfied, and even more so in terms of extremely satisfied ratings by the Watchman group. When we asked the patients, do you trust that the virtual form of cancer surveillance is as same level of excellence as your old-fashioned in-person visits? And nearly everyone agreed, with almost 2/3 strongly agreeing. And then this to me was the most interesting piece of data of all, is that if you had to receive bad news, in other words, if you had to find out that your cancer had come back, would you rather receive this virtually or in person? And us as physicians were trained to think that, well, the only way to deliver bad news is in your office with the right setting, and you can read their body language, et cetera. And it's interesting, these patients, nearly 2/3 of them said they'd rather find out that their cancer had come back virtually on the app. And once I saw this, to me, sky's the limit. If you can overcome dealing with delivering bad news virtually, then anything else can be accomplished, because as long as you stay engaged with those patients, they'll still trust you. And so this to me was the big win for our program. So my final slide, I think what our Watchman app, again, with the help of so many people in this room, we've proven that it's feasible to watch for cancer surveillance virtually. It's safe and in fact preferred by the patients, and we have some level 1 data through that with our Watchman clinical trial. And the next step, which we're working on, of course, we've rolled out already version 2.0, which has a more fancy user interface. But our next step that we are grant funded to do and working on right now is rolling in aspects of artificial intelligence to try and curate some of the sort of mundane routine tasks of surveillance that maybe don't need a clinician's direct attention, and saving the clinician's time for the patients that really need it, who have relapsed, who have mental health crises or physical crises on their cancer journey. And it may actually improve the quality and the safety of the surveillance that we're doing for these patients. So that's our next goal. We're working on that right now. And I just put this little plug at the bottom here because we can talk about this in the panel. But one of the big barriers to adoption of virtual care, at least in the province of Ontario, and I think this is true throughout Canada, is that asynchronous care, where the doctor and the patient don't align at a specific point in time, is not reimbursed by the Ministry of Health. So a physician cannot bill for that interaction. I don't know how it works at the cancer center level, but I suspect there's similarly not a remunerable interaction there. And as long as that is in place, that will unfortunately be a barrier to widespread adoption of these programs and programs like this that we've worked on. So I'll stop there. I look forward to the discussion. Hope I didn't take too much time, and thanks again for the invitation.
Okay, so I'll keep you all on your toes, I promise, even if you're sitting down. So the first question there. I had a bit of a different question prepared, so I'm going to blend them both, because one of the questions is around, some people, these programs need technology, phones and smartphones and stuff, so there's people that don't have the digital literacy. So how do you make sure that you're not deepening inequities? On the other hand, the remote service can help people who are in more underserved areas and where they also have some limited resources and so things like that. And they tend to collocate with the digital literacy. I'm not saying they're always one-to-one, but so there's a good side of it because it's access and you can reach these people. On the other hand, you can introduce more divide and more gap in the healthcare. So how you reconcile those, how you make sure that you're not making more harm than benefit here.
Go first if you want, yeah. Is this on? Good. A great question, and I'm curious to hear what the rest of the panel thinks. And I think, Ali, you alluded to it, there's advantages and potential disadvantages. I think the onus is on the healthcare team. You still have to make that first contact with them at the time of diagnosis and prognostic information that you give to the patient. And you have to make an assessment of whether they're right for virtual care, and not everybody is. And I think that as a healthcare team, you have to be able to to offer both forms of care, because if the patient doesn't want virtual care, you shouldn't force them into a virtual care situation. And there may be scenarios where you feel as the physician they're not best served with virtual care. But the advantages, particularly the geographic advantage, there are very few places in Canada and even in Ontario that can have the really specialized care that testicular cancer patients need. So if you live in Kapuskasing or Thunder Bay or what have you, to be able to stay connected to Princess Margaret, I would say trumps what potential disadvantage someone who may be not as health literate or as tech literate may be. So you have to suss it out with each patient, but I think there's usually a win that can be found there.
Yeah, I mean, I would agree. All right, thanks. I would agree. I mean, for us too, we assess our patients, and they have a choice between in person or online. So we offer both. It's hybrid. So there is the option to do everything in person if they prefer. But I think, as I mentioned, there's this large proportion of patients who wouldn't get access to our rehab programming if we didn't have our at-home program. So it just absolutely increases access. And you'd be surprised at how many older people now have devices and are really literate on digitally literate and are able to use, love their Fitbits. I mean, we give lots of support. We teach them how to use it. Some of them don't go on the app and stuff like that. They just wear their watch. All they have to do is look at their steps. It's pretty easy. These things, and you can work with the designers and things to ensure that you're really making sure that all the things are easy to use. There's big font, so there's design things that you can build in to make it more accessible.
I would add that with the Watchman program and virtual clinic, it really was no different than emailing and how you would communicate virtually. So, I think if you're struggling to do those things, that's a whole other scenario, and virtual care is just likely not in the cards. But from a patient perspective, there is some responsibility for self-diagnosis and self-understanding. You have to be able to understand what your own personal limits are.
So I'll pick, before jumping to the next one, there's some mentioning around the number of apps and stuff. We're going to get there, but also the limits of this literacy and the number of apps, because Unique had, let's say, Watchman, and you won't use any other PM app, God willing, but then you may need hypertension app, then you had a broken ankle, playing hockey, and now you have the hockey app, and suddenly you have 15 apps, plus your email, plus your Ring, plus your WhatsApp and everything. Isn't that like a huge concern for us?
It is for me as a patient. There's too many apps out there, generally speaking. And I saw the question pop up, and I'm curious to hear everybody's thoughts, because it seems like there's a lot of apps being developed, different websites being developed within Princess Margaret. My UHN is a great platform in and of itself that exists as kind of a centralized place as well. And there were times, even during my own surveillance, that there was a little bit of overlap between what I was able to see in my UHN and with Watchman. So you're kind of seeing things in both spaces, even though the communication is heavily coming through the Watchman platform or email or what have you. I think thinking about the user's experience and not diluting or confusing the best path of communication, I think that's what's essential. Making sure that they know the right way to approach their care provider and that team, and making sure that that's as clean as possible is always just going to be helpful.
Yeah, and I would say, for some of these apps, they really are time limited. You're not using them for the rest of your life, right? So it may be that you just use the app for a certain amount of time when you're going through treatment, or when and then you'll never use it again. And it's the same if you have to go to a clinic and 5 different clinics or 5 different doctors that you have to see for all your different things. If you had to go to the hospital 5 different times or different places around the city, I'd rather just use the different apps personally than have to do all that travel. But I think for a lot of them, I don't think we should quash innovation. I think we should be developing all these apps and seeing which ones people really like and which are most useful. But I do think we have to be mindful of overloading people.
And I could just add briefly, I know you want to get onto that, but I mean, there is crosstalk between app development and communication. And I can give you an example. For our creation of our 2.0 version of Watchman, there was overlap with what the Healthcare Human Factors and TechNet team had done with NED and vice versa. And deep buried in the code, and there's people in the room that can talk about this much better than I can, there's 100% overlap and utilization of the constructs of the app. And a lot of the functions are very similar. And so it's not that we're creating these independently and without knowledge of whatever else is going on from scratch. So we are capitalizing and leveraging a lot of resources that have already been used to build the other apps. So, but I echo what my other panelists have said.
So I'm going to pick up on that. Like, you don't want to stifle or inhibit this innovation, but the way it's happening, and it's perhaps a phase of maturity that there's a lot of duplication and everyone is reinventing the app, and most of these apps are hard-coded and they're not modular and things like that. So is there a better way to do this at an organization level? Should we be thinking on that, or that's not a problem for us to solve?
I think there's a better way, personally. I mean, I think, first of all, I don't even think that we're aware of all the different apps that are happening in our hospital. So just knowing what's out there, and that would help to reduce duplication right there, knowing what other people, and if you can build on something that somebody else has done, it saves a ton of money and time. But yeah, I think that would be great if it's more centralized. I think CDI can play a really important role in that. I think we should prioritize things that are, so that we're not overloading people. So yeah, I think there's definitely things that we could do to improve it.
That's funny. So prior to cancer and the journey that followed that, I was a product manager for an application, and I got to see kind of the whole side of things, and I can already tell anybody in here in IT is already just like trying to avoid this conversation because it is such a headache to try and merge all these pieces. And even though our app was it was fairly singular. It was, for those of you who have Bell Fibe TV, there's an application for your phones, and I developed that. And we had many teams within that would be responsible for the live service, the on-demand service, the recordings, and I found that each team bumps up against one another, and you end up almost having more crossover, more issues. One team wants to push something live, but the back end is, there's so many issues on the technical side that I do think that having all these teams developing within the same ecosystem, it could cause a lot more issues for patients.
I agree with all of that. I think we have to recognize, though, that the base infrastructure of our healthcare delivery, at least at UHN, like these things change over time. So even in the course of development of Watchman, we went from a time where we had old-fashioned EPR, no patient portal, and then we went through a phase where we had a patient portal, and now EPR becomes Epic. And I remember there were conversations about, okay, we know there's some functionality in Epic. Should we stop what we're doing in developing our Watchman and just wait and see what happens with Epic? So I think we have to be careful with saying, oh, let's everybody wait, let's everyone talk to each other, let's come up with one big $5 billion plan to solve all the apps, because that will quash sort of individual innovation pathways that are running forward. So it has to be a happy medium in there.
So there's a bunch of questions here that I'm going to take the moderator dictatorship mode, that they're not applicable to this panel, because the first one is around Epic and scalability and how scalable and what the organization wants to do with it, because we don't have our Chief Information Officer or our CEO here to answer that question. Also, Keith has a great question around a lot of apps developed here locally, but how do we know they're best in class? Should we have an ARC kind of environment and put them in the market and let it choose? I guess the answer is yes. So we can move on, Keith. I said I'm going to use my prerogative of it's solved, like yes. So I want to move something around again. Let's go back to the patient experience, because a lot of the discussion here, Keith is my boss, by the way, so it's good to give me my 15 minutes of excitement. So the other thing is around the empowerment of patients and choice of patients. We've heard these a lot of times, like give the patients a choice and everything, but we lived before in a world for decades, patients had no choice. You had to come to clinic. So why are we now so fixated with this idea they should have choice? If we think certain care should be virtual, what's wrong with give that as the only option, as long as properly safeguarded? Does that make you uncomfortable, or what are your thoughts around that?
It's a good question. Like, why don't we just tell, if virtual care is so great, why don't we just push that on everybody, right?
In certain scenarios. No, I'm not saying like, we're not saying an ICU patient is like, oh no, it's virtual care, go home with all these cables. But we're saying in this, like example, your case, there's no in-person option. We just provide virtual care for these patients, as long as few exceptions, of course.
I mean, as a patient, I don't see a lot of issue with that personally. We don't know how the system works when we enter it, realistically. When I came in to the oncology department, I really had no idea what to expect going forward. And if Dr. Hamilton was like, this is how we do care, you kind of take that at face value as a patient as well. I do think that empowering them to take control of their own care is an interesting framing technique, because it kind of gives me the power to move my surveillance forward. You want the patients to be as engaged in their own care as you can be. You're sending notifications to go get blood tests done, go get scans done, and we're responsible for taking that on. So I do think that leaning on us and giving us that power does add something, but I don't think we would be caught off guard if somebody was like, this is how we do care going forward. Especially now, post-pandemic. I mean, people are so used to remote conversations. I mean, even in film, like all of my meetings are digital these days. We're meeting with people in LA, but like you're not going there anymore, really.
When the pandemic hit, we actually did a study over the first 3 months, and we had obviously had to switch all of our rehab to virtual. We had already started doing virtual before the pandemic, so we were in really good position to just switch. Like on the Friday, we were told no in person, and Monday everybody was virtual, and we already had that set up, so that was fine. But we wanted to learn about the patient experience going through it, and like knowing that the pandemic would end, what could we continue doing virtually, and what makes more sense that has to be done in person from a rehab perspective, because we do actually have to put our hands on patients at times. So it was great. We followed patients over the 3 months. We interviewed them about what was acceptable to them, what they felt comfortable doing. And so now there are certain appointments that we just offer virtually. That's just, this is a virtual appointment. We know we can do it virtually, and we do it virtually, and other ones where we know we have to see them in person, and virtual isn't really an option.
Good.
I want to add one thing. Just one of the most important things that I found through the Watchman and virtual clinic and all that was just the consistency of communication between patient and clinician. There was never a point where I felt like there was a gap in communication. I knew what to expect at every single month. I mean, you all saw the schedule of the 5 years that we were on, every other month, every 3 months, every 6 months, every year. And to constantly have a quality feedback loop with the care team, it made that whole thing super smooth for me. And I can look back and I can see every form of communication that I ever had with my clinician. Every virtual clinic was tracked and available to me online. So there's something about that made the virtual care just so seamless for me.
So now that we're like putting so many flowers into virtual care, I'm going to tackle the elephant in the room a little bit, because Rob alluded to these around reimbursement and payment. So physician, I'm going to burst a bubble here. Sorry, Rob was always seeing you in clinic, because every time he sees you, this is public information, he got a check for $60. So the question now is that
60.
65.
Not that much. No, wait a minute.
It depends which code he used.
Radiation oncologists have a elevated scale.
He's a whiner.
Much less.
So So the question now is, what's your perspective here? Should he be remunerated the same, less, more, or depending on what type of visa? Do you think it affected the responsibility and care, or?
I mean, just to be clear, I think that asynchronous should be fully paid out the same as synchronous. I mean, you're not doing different work, and hopefully you can do it smoother, faster. You're able to move through. Like, we have a backlog in the Canadian healthcare system, and you know, we're potentially going into a new vote for the Ontario government, and I feel like healthcare has consistently been underfunded with the current government. So I'm curious to see. I mean, who knows? Who knows where this is going to go? But I do think that like asynchronous needs to be something that's relooked at. We've gone through a pandemic; things have moved online. You know, lots of walk-in clinics shifted virtual throughout that whole time, and we're still delivering the same quality of care. So yeah, I think we need to relook at what that.
Thoughts from the provider?
The rich provider, according to yeah. So many jokes I could make. Yeah, exactly. No, but I mean, for the record, every single one of those 650 visits and all of our research creation, we did, all of us, including you and Ned and all that. It's all part of the research stream. So. It's not about the money. If I had known how much I love this guy's thoughts, maybe I should have brought him back into clinic, because I agree with everything you said. I don't know if there's anyone in the ministry in the audience today, but I think this is the way of the future, or part of the future. And if you don't fund it, it won't be. And I think that's the bottom line. And part of the reason we tried to show efficacy and safety was specifically to inform these decisions. And I think if you have something that's just as safe, maybe safer, the patients like it better, the physicians like it better, it opens up more resource at your hospital to see more of the patients that actually need it. And you can go even further. If one patient on a Tesla's cancer journey misses their CAT scans and markers because they live far away, they're not connected, they don't show up for their appointments, and they relapse, and they need chemo and salvage chemotherapy, high dose with stem cell transplant and a retroperitoneal lymph node dissection, the cost to the system of that one patient pays for the entire surveillance journey of another 1,000 patients. And so I think that it's hard to argue on the financial side of funding virtual care, asynchronous virtual care.
So we're in an academic environment. You're both super researchers, and most of these things has happened in an academic environment with its pros and cons. This could also be happening with different diseases, or the volume becomes an issue in a periphery, smaller hospital, which could be more nimble, faster, less red tape, and so on. So what is our advantage in a center like this? Besides the volume question, is like, are we making it advantageous for developing this sort of stuff, or you're doing it in spite of the environment, would you say? You can be very provocative. Brad is distracted on his cell phone, so it's fine.
Well, I mean, from my perspective, I mean, we're the only rehab program really in Canada. So we are very privileged to be supported by our foundation to have our program, and also the research to support the research that we do. I feel like, we're the hub that can create the evidence then to make that case for rehab being standard of care across all Canada. And we are trying really hard to develop programs that are cost-effective, sustainable. So the Care at Home program is a great example where you don't really need a lot of infrastructure to offer that program. So right now, we're testing it in a large effectiveness implementation trial across 4 centers in Canada. But those 4 centers are really interested in it because they don't have a lot of infrastructure, but this is a program they could offer because it's entirely virtual. So they can do the assessments and then offer rehab to patients from, especially in places like Newfoundland, which is one of our centers. Patients are traveling from so far away. So I feel like we're very privileged here at Princess Margaret, and very lucky to have the opportunity to have these integrated research programs within our clinical space, and to be innovating and developing these new programs that then can be applied elsewhere. So,
Yeah, I won't take long, I promise. But I feel it's part of our academic responsibility. Like, TELUS is going to do virtual care. If they can make money off it, they're going to do it. And I just named them. The other people will do it. The way I see part of our responsibility as researchers is to prove with evidence what's safe and what's feasible and the pros and the potential harms, ideally before, but if not during, the sort of mass rollout and adoption of these third-party for-profit sort of aspects of virtual care. The same is true for other healthcare. I mean, there's a lot of things we do at academic centers strictly to prove for safety purposes. And yeah, you could do it at a community center and roll something out in a month, or do it with third party like TELUS or whatever, but there's a burden of proof that you have to achieve, and I think that's part of the responsibility as an academic health center.
But there's I was also thinking on the development piece, because that's more on the evaluation, implementation side of things, which is not trivial, but I would argue that TELUS is perhaps better, faster, and cheaper developing software than we are. So how do you allow not to fall back into, okay, we'll do it all, or like where is that sweet balance, you think? Like where the academic environment becomes a barrier for the optimal state versus an advantage?
Well, I think we'd all agree there's tons of red tape across our institution, every institution, and just across Canada in general, like that makes innovation really difficult. I personally have always just loved the fact that there's like TECNA and now CDI, and whenever I've come up with an idea that our team has sort of come up with some ideas of a new program or new app or something, where I just email Tran, and it's like, hey, let's like, you want to play? Let's do something. And her team's always super keen, and it's like it's such a great environment to be able to do that. So I don't know, I don't find it slow. I find, there's a lot of excitement here at UHN to do stuff. But I think that there's just so much red tape around even just our privacy department. Like, you trying to use a new app. Privacy, REB, they don't even know, like it's really difficult to go through that. It takes almost a year just to go through the privacy and the REB to use a Fitbit, So, like, it's just those types of things are frustrating, which I'm sure outside of, UHN and in industry, they probably don't have those barriers maybe.
I'll say as a patient, like, I understand the privacy and all that kind of stuff. It frustrates me that more of my data is not just widely available to care providers. I mean, I have an Apple Watch for the last 6 years, and it's tracked all my heart rate for that entire period of time, and I should be able to just hand that to somebody very easily, or have that readily available. I was talking with my family doctor recently about even just childhood vaccinations and all of that, to know that none of that's shared across the board and it's isolated is wild to me. And I think it is something that's necessary in our healthcare, that like information is a little bit more available, but yeah, there's a lot of red tape to doing so, because there's a lot of risks with that too.
But Nick, you can complete an online form and request all your Epic records, and within 28 business days, you're going to get all the information.
There you go.
So I think we're in lunch time. I just want to do a quick question, because we saw a spectrum of things between high complexity, very sick patients, but low mid volume, versus high volume, lower complexity type of things. It seems that we're only in one bucket playing. Do you think we should put more effort on the high volume, low complexity stuff, because that's a bigger impact at the end of the day, or you think we're doing the right mix for an academic center?
I guess I can answer. I mean, we wanted to test it in the high volume, low complexity for proof of principle. But our plan was always, and within Testis, we have, fortunately, a much rarer percentage of the Testis group, but there are some very complex, multidisciplinary rad-onc, med-onc, surg-onc, hematology, oncology. So our goal was always to expand once we had proved safety. So I think across the different diseases, that's the starting point, is proof of principle in something where the complexity is low. Not to say the stakes aren't as high, but I think one could argue that if you miss something, it's perhaps not as high as if you miss someone who's undergoing CAR T therapy or whatever. But so I think you start low and then you build it up. I mean, I don't know how else to, that's my approach to it.
I mean, I think there's a space for both. I mean, you look at Dr. Laframboise's work and her app, like that is a smaller portion or group of patients that are very high risk, but it's, very beneficial. So I think there's room for both, for sure.
Awesome. So I want to thank the panel, Nick for the openness and the candid inputs, Rob, Jenny for amazing work that is being done, and remind everyone if you have any IT needs, it's tran.truong@uhn.ca. So thank you very much, and we'll see you at 1:30 with Mike. Thanks.